Dr. Kevin Frick will now discuss updated findings related to the impact of adult eye disorders, visual impairment, and blindness on the U.S. economy. Dr. Frick is a health economist and a professor in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. He's written extensively on the costs of medical care associated with blindness and vision impairment, potential productivity lost due to blindness and vision impairment from both disease and for both disease and uncorrected refractive error, and the cost effectiveness of a variety of efforts to prevent vision impairment and blindness. Dr. Frick's work will be contributing to an updated report on the cost of vision problems that Prevent Blindness America hopes to release later this year. Dr. Frick.
Thank you for the invitation to present this morning. So what I'm going to be talking about this morning, as you can see, is the excess cost of low vision and blindness in terms of three very specific types of costs: medical care, informal care, and the value of the loss of well-being or the loss of quality of life. So I want to first define the burden of disease that we'll be talking about this morning. I want to talk about the data that are used to produce the estimate, and then talk about the methods that are used to produce the estimate, the results of the analysis, and then thinking about what comes next. So it's important to understand what the burden of disease is measuring and what it's not measuring. When we talk about burden of disease in this context, and as it was used in the earlier report on the cost of blindness in the United States, we're talking about the economic impact from a condition in a given year. Now, clearly, conditions like permanent loss of vision and blindness impact the individuals, their families, and society in general over the lifetime of the individuals who are involved. But we're focusing just on what is the cost in 1 year. So that's one important distinction. The other key thing about the measurement that I'm talking about today is what's in it, and just as importantly, what's not in it. So the three things that are included are the excess medical care that is consumed by people who have visual impairment or blindness, and we'll look at what some of the components of that might be. And I remember when we did this originally and reported on it back in 2007, we were actually a bit surprised at where some of those big chunks of the cost were coming from. We'll also talk about the cost of informal care, or the care provided by friends and family that's given for free. Although obviously anybody who's ever provided care for someone who needs extra care knows it's not free in terms of the time and the things that have to be given up, and so we'll try to put a dollar value on that as best we can. And then we'll talk about the loss of quality of life and how we can place a dollar value on that as well. What you'll notice is not up here on the list is the cost of treating ongoing disease, like Beatrice had just talked about, the ongoing AMD, or the diabetic-related conditions, or cataract or glaucoma. Those in the previous report were analyzed by a different research group, and updating those requires some work that's separate from the work that's being done here. So as in the last time Prevent Blindness America reported on this particular topic, I'm focusing on people once they have a visual impairment or once they are considered legally blind, and focusing on these three elements. And of course, the two conditions, as I mentioned earlier, are vision impairment and blindness. Now, the data come from a study called the Medical Expenditure Panel Survey. This is an ongoing study with overlapping panels. Each person is in the study for 2 years. So they get contacted at 5 different points in time over a 30-month period. Now you're probably thinking, okay, 30 months, that's a little bit longer than 2 years. Why do they need that? Well, they don't interview everybody, starting on January 1 and ending on December 31. And so what they do is they interview people enough times so that the researchers at AHRQ, the Agency for Healthcare Research and Quality, which is part of our Department of Health and Human Services, can add up all of the medical care expenditures that the study subjects experience during calendar years. And then we can look at calendar year totals of things like medical care, of things like days of informal care, and any other expenditures that we want to look at. So we're using this as a combination of cross-sectional data because people are interviewed again each year, but we're also looking at it over time. The time period in question this time, we're able to get data from 2003 up to 2009, so that's a nice improvement over the data that were used in the 2007 report, which went from 1996 to 2002. So much more recent data, and we're able to look at, are people who are blind or visually impaired still paying as much extra now as they were the last time we produced a report. And these data are gathered in a way that, and then analyzed in a way that the findings can be considered nationally representative using the proper weights and the proper regression analysis techniques. And what this allows us to do then is it allows us to estimate the medical care costs, the informal care costs, and aspects of quality of life and place a dollar value on those to come up with an overall estimate. So again, the previous work used the 1996 to 2002 data from this survey. The current work used 2003 to 2009 data. Along the way, the Agency for Healthcare Research and Quality increased the sample size, so there's more individuals in the sample total each year, which leads to more visually impaired and blind individuals, so we can get a better estimate because we have more people who we have data on. And then we adjusted all of the costs up to $2,011. So despite the fact that the data were gathered from 2003 to 2009, we used some standard approaches to adjust for inflation, because as we all know, inflation is certainly not zero, and inflation in medical care is definitely not zero. And so we made it into 2011 costs. And to come up with our final national estimates, we applied these data with the 2011 cost to the 2010 prevalence figures that were discussed earlier to come up with an overall national estimate. So the prevalence figures, again, based on updated epidemiological data as well as updated population data as was just presented. Now, we have a linear regression analysis. What does that mean that we did? Well, we didn't simply ask if we take the average medical care expenditures among people who are legally blind as reported in the survey, and we compare that with the average medical care expenditures with people who report no problems with their vision. What do we get? I have that figure to show you, and it's a very large figure in terms of the extra amount. But what's key is the people who are legally blind might be different in some very important ways from the people who report normal vision, at least on average. They would be an older group. They might have differences in income and education. And so we use a linear regression approach to try to control for those other confounders. And we account for the weighting of the observations, and we account for everything that needs to be accounted for to use the medical expenditure panel survey data correctly to come up with a nationally representative estimate. So our three dependent variables, we have total medical care expenditures, and then sometimes we look at subsets of medical care expenditures. MEPs allows you to look at a variety of subsets, some based on the category of the expenditures, like home health agency costs, or prescription drug costs, or costs related to dental care, just as three examples. It also allows you to look at expenditures by who is paying. And we're going to focus on expenditures out of pocket and ask, are the people who are legally blind or visually impaired experiencing greater out-of-pocket costs? Not just greater costs in total, but greater costs out of their own pocket, because as was mentioned by the fact that many of the older adults who have this problem are 250% in poverty or less, and the question after the earlier presentation, it might be an important amount for these individuals. Then we're going to look at the value of days of informal care provided by individuals who live outside the household, and then a quality of life measure translated into this metric called quality adjusted life years, which is sometimes used in cost effectiveness analysis. And we don't have a fixed value that our government has ever said this is exactly how much a quality adjusted life year is worth in the United States. But if you read the cost effectiveness literature looking at different interventions that can be implemented to prevent blindness or prevent a variety of other diseases, you'll find a standard amount that's used in the literature, even if it's not a government sanctioned amount, that we can then apply and say if a quality adjusted life year is worth this much, we're losing this many dollars associated with quality of life and just general well-being on an annual basis. So the category of expenditures, I mentioned one, home health care agency cost. In the previous report, this was one of the largest single categories of different expenditures between people who were blind or visually impaired and people who reported no problems with their vision. And we're also going to look at prescription costs, and I mentioned in terms of who's paying, we'll look at out-of-pocket expenditures, both because it's a direct burden on the individuals who are blind or visually impaired, and because it's one cost that everybody's eligible for, okay? When we look at individuals 40 and up, only some of them are going to be eligible for Medicare. Only some of them will be eligible for Medicaid. Only some of them will have private insurance. But almost everybody is going to have at least some expenses that are out of pocket. And the way that the Agency for Healthcare Research and Quality collects the data on expenditures allows us to separate and understand how much people are paying out of pocket and how much is paid by the different payers. And it's not always perfect. It's not like claims data in terms of its level of precision, but it certainly has been used, in addition to by myself, to estimate costs related to blindness and visual impairment. It's been used to estimate costs related to a large number of other conditions. So these data are taken as reasonable data for this purpose. When we estimate the value of informal care, we have supposed that the value of a day, of an hour of informal care is essentially equal to the wage of a home health worker reported by our Bureau of Labor Statistics, which is under the Census Department, and that's $9.70 per hour. We could try to estimate the value of time for each individual who's providing care, but we don't really know much about the individuals who are providing care. So assuming that an hour of informal care has the same dollar value as an hour of formal care is a reasonable assumption to make, and we can always do some more estimates testing what happens if we raise or lower that number. And we are going to assume that each day of informal care is 8 hours. For the quality adjusted life years, there's a lot of information on the slide. There's two important facts. In the earlier study, the Agency for Healthcare Research and Quality, when they surveyed individuals for the Medical Expenditure Panel survey, they had used an instrument that could allow us to get directly at quality adjusted life years. They took that instrument out of the survey after 2002. And so after 2002, they continued asking about quality of life using a different instrument called the SF-12. It's a 12-item questionnaire. It gives you a mental health component and a physical health component. And while that is not directly a quality of life measure, there are algorithms available to convert it into a quality adjusted life year measure. And then, again, the most commonly cited figure in the United States for how much a quality adjusted life year is worth is $50,000. So applying $50,000 to each quality adjusted life year lost, we come up with a figure for the value of the loss of well-being among the population that's living with visual impairment or that is legally blind. Now, the independent variables, the condition itself, low vision and blindness, is identified by self-report. It is a very simple question. It asks people to say, on a scale of no problem seeing to legally blind with those three categories in between, where they would rate themselves. And we take the three intermediate categories and group them together as vision impairment. Other potential confounders, so this is the value of doing a multivariable analysis to try to control for other things and make the individuals we're comparing with blindness or visual impairment as comparable as possible to the individuals without. You can see the list of things that we've controlled for. Some of the major things: age and sex, income and education, high blood pressure and diabetes, to make sure that, for diabetes in particular, if a person has a diabetes-related eye condition, we're not picking up the cost of diabetes, but we're picking up the cost related to the eye condition. So if we just take simple averages and we don't do any of the statistical adjustment for any of those confounders, we don't say the fact that they're an older population or a different population in other ways, we find that people with vision impairment are spending $3,800 more than people with normal vision, and people with blindness every year are spending over $8,000 more than people with normal vision. Those are big numbers. Those are important numbers. And regardless of who's paying for them, those would be very important numbers. So the next question is, once we control for those confounders and ask, if we make the populations as comparable as possible, how much is remaining? Well, what we find is that those numbers get a lot smaller. The amount for people with low vision or vision impairment goes down to about 1/6 of the unadjusted amount, or you have a difference of $633. And for those who are blind, it goes down to about 1/3 of the unadjusted amount, or $2,800 per year. So that means if we compare people as closely as we can, same age, same amount of income, same education, same comorbidities, that this is what we have left in terms of a difference. Still very important, but not as large as if we took the unadjusted difference. A few other facts and figures that we can come up with. Per person excess pharmaceutical costs makes up $150 of that $633 remaining difference once we do the adjustments for people with vision impairment, and nearly $600 of the difference for those who are blind, although it's just shy of being statistically significant. Home health care agency costs. Now, the low vision population or the vision impaired population is not being hit too hard there, about the same amount as for the pharmaceuticals. But for those who are blind, again, it's about 1/4 of the total is made up of different home health care agency costs for people who are blind. And then in terms of out-of-pocket costs, again, for those who have a vision impairment, it's about $152 more in out-of-pocket costs. Interestingly, more than for those who are blind. Going to do a little bit more exploration of that. But regardless, the extra $150 a year in out-of-pocket costs, while it's not in the thousands, is something that for individuals who are living at 250% of poverty or less could be a big deal for them to figure out where that money is going to come from. When we look at excess days of informal care, it seems quite small. That was definitely my gut reaction the first time I worked on the report, and definitely my gut reaction again this time. And the key is this is only people living outside the household. And I would bet that a lot of the support that they get is provided by their spouse if they happen to still be married, or someone who's living in the same household that they are. Nevertheless, we can put a dollar value on that. This is on a scale of 0 to 1. The differences seem quite small. These are not inconsistent with the differences that we found last time. A little bit smaller, but not inconsistent with the differences that we found last time. So when we put dollar values on everything, you can see that we can break it down into the different categories of medical care cost and informal care. Add those two up. That's what the direct plus indirect in the middle column, in the middle row is. Then we have quality of life cost and total including intangibles. And then we have the total for each category as well. And you can see that when we add everything up, we get close to $17 billion compared to the report that was released 5 years ago, which was just around $16 billion for these three. That's $1 billion every year increase. And that's driven by changes in the prevalence, changes in the cost. And the important next steps then will be to think about how to include the cost of managing the diseases and a little bit more exploration of some of the details of what contributes to these cost differences that we are observing at the present time. So thank you for your attention this morning.